I'm going to try in the course of the next 45 minutes to an hour or so, talk to you a little bit about the work that we do in London, a little bit about the basis behind why we do that work, what transition really means to us, and by implication then I hope what the value is in it to you, and if you're parents rather than patients, to your children. So there's a lot to get through in that. It sounds relatively straightforward, transition to adult care. But really, I suppose if you think about it slightly differently in terms of what it means is that we're dealing with a set of conditions, and I'm going to talk about a range of conditions with a focus on extrophy. We're dealing with a set of conditions that begin very early on in life. Many of them are congenital, i.e. patients are born with them. They need treatment early in life, but they are conditions that have implications either by virtue of the condition itself or the treatment that's required for that condition right through into adult life. And I'm going to talk about some specific examples of that and why our team is involved in looking after patients throughout their life. And so I thought it would be reasonable just to define for you a little bit about what it is that I am. And so I'm trained as an adult urologist. That's the basis of my training. I spent some time working at Great Ormond Street Hospital in London and learning pediatric urology, but I'm not a pediatric urologist. The reason behind that training was that it allowed me to understand the basis behind diseases, conditions, and their treatment, so that when I come to look after those patients as teenagers and then adults, that I understand exactly what's happened to them. And it also helped me to form really valuable relationships with our local pediatric urologists so that I could interact with them throughout the care that I give for our patients. So I'm a bit of a gatekeeper. I deal with a service, I manage a service, I have a team of people that I work very closely with, and I'll talk more about that team later on. For a lot of our patients, thankfully, they go through large portions of their life without having problems. So I'm something of a night watchman. I'm keeping watch, and making sure that things are safe. We have patients who drift away and drift back, or patients even under our care who fall into trouble very quickly. So I become, with my team, a safety net for them. There are times when I feel like a last chance hotel. I'll get a very long letter from a physician elsewhere specifying the concerns and the difficulties and the iterations of treatment that a patient may have had. And really, we've run out of ideas, so over to you. And that's part of what we enjoy doing. We enjoy looking after people and taking them on, bringing them into our service and trying to look after them in the long term so that they don't have to move on elsewhere and they have that security and stability in care. When you deal with a set of conditions or a set of operations that are relatively rare, in this world where finance is important, you start to wonder whether you're a luxury, and making sure that you justify your existence, that you continue to provide good care, and you continue to make sure that there is value in that care for our patients, but also the providers as a whole, is important. The last two things I think are important. Occasionally I'm a surgeon, and that's what I'm trained as, and we do regular operating on complex patients in our service. But most importantly, I think, as a team, what we try to do is to instigate continuity in bringing people from pediatric care into adult life and helping to look after them. And that's the kind of framework of the service as a whole. When I began my job, I took over from a really amazing gentleman called Christopher Woodhouse. And if you've read anything about transition care, his name comes up pretty often, so you may have heard of it. But he's an amazing man who, with his pediatric colleagues, really understood that this need for patients who are growing up, having had major treatment in their pediatric lives, were going to need care into adult life. And he called that initially adolescent urology. Since coming into the world and looking after these kind of patients myself, I felt that we needed to change the philosophy a little bit and try and make it feel more seamless. And so rather than having pediatric urology, adolescent urology and adult urology, that you'd have one continuous flow, congenital lifelong urology, allowing patients to move through this system and be looked after throughout it. And hopefully we'd make some of the road a little less bumpy by doing that. So why? And really, the majority of my talk is about why, and why transition is important, why long-term follow-up is important, and therefore giving you a little bit of a flavour of the type of service that we have in London and the value that I think that we offer. So if you think about these disease processes, and you'll have heard of asthma, you'll have heard of diabetes, you may or may not have heard of Crohn's disease, an inflammatory bowel disease. Obviously, we've all in the room heard of exstrophy because we're here, and posterior urethral valves. Then we know that if you're a child with asthma, that there's a pediatrician that will look after you, and there's an adult respiratory physician. We know that if you are born with diabetes or you develop diabetes in childhood, that there's a diabetologist or an endocrinologist that is very well acquainted with you that will look after you into adult life. The same for bowel diseases too, that there are pediatric and there are adult gastroenterologists. Well, if you're born with bladder exstrophy or posterior urethral valves, then actually adult urologists aren't acclimatized to dealing with those kind of conditions. They are excellent urologists, and they'll look after a range of conditions extraordinarily well. But understanding the pediatric basis of care behind bladder exstrophy or posterior urethral valves is complex. It's relatively rare, and it's not something that they will see in their everyday practice, and so they're not as familiar with it when you go and see them in an adult clinic, and that's not their fault. That's simply the design of a system and the needs of the healthcare population that they serve. And that's why there's a discrepancy, I think, in the care of moving patients sometimes from pediatric urologists into adult care. There is a healthcare need there that is now, I hope to be able to tell you by the end of this talk, or convince you by the end of this talk, that is gradually starting to be met. So we in Europe began a thing called the Congenital Lifelong Urology Group, which was kindly supported by the European Association of Urology, which is nominally an adult association. It has some pediatric work within it, and the European Society of Pediatric Urologists, which is very obviously the Pediatric Urological Association in Europe. And we began this working group really to start to try and address this problem, to create a network of people that were interested and involved, and start to build that network and become inclusive in the way that we deal with these patients. Because if you don't see a lot of this kind of work, and somebody comes through your clinic door, who are you going to call? Well, this network of people is really designed to try and help with that and support doctors who are looking after patients to try and improve the care of patients as a result of doing that. And so in terms of what we want to get out of it, is really recognizing that when you have any kind of disorder that involves all sorts of areas of care, that has all sorts of implications, that you need to be brave enough to involve those areas of care, and that's what we call multidisciplinary care. So involving other partners, that might be nurses, it might be other kinds of physicians, radiologists, psychologists in some instances, get them involved so that actually we can provide the best care. Because I can't do all of that, I'm only a surgeon. But I can do lots of things. I need other people alongside me to deliver the best care I possibly can. We need to think about getting more people involved. I've already alluded to the fact that there's a gap in this area of healthcare that is starting to be met, but actually by setting this up, one of our objectives was to try and bring more people on board, make it more available to people, and to create a network that would help us look after patients better. That's really what we wanted to do. And then in the longer term, what we hope to be able to do is to start to provide standards and to educate people who are coming on after us in healthcare to be able to provide this care better and better, generation by generation. So it's a slow build, it's a long game, but actually we're involved in it. It's a very active process, and I work very closely with partners here in the US. Rogers very kindly had me out here before to visit here. We have links with Indiana, with Cleveland, and with other centres across the US. So there's all sorts of work going on, and I'm delighted to be involved in those conversations, be a part of it. But transition is what I'm going to talk to you about first. And transition, a lot of people make the mistake of thinking that transition is moving from one hospital, one set of healthcare providers to another, whether that's pediatric to adult, from this side of the street to that side of the street, however you want to frame it. That's what people believe transition is. there's a lot to that, and what's really important as part of transition is that we understand what's happened to somebody prior to getting to that point and what the future looks like for them, and that we try and, as best as possible, design healthcare around those needs rather than what we think as doctors. And that's a challenge, and it's not always easy to meet that challenge, but it's a really important part of healthcare in this area. So these are some quotes that just reflect what it's like in the adolescent world. Now, some of you may have had adolescents that are passing through healthcare at the moment. Some of you may even be adolescents. Some of you may remember being an adolescent. But we understand that adolescents are pretty rebellious. They can be difficult. They can cause us all sorts of problems that we may not have expected, and sometimes we don't even find out about them until way after the event. And there are certainly anecdotes that I could talk to you about where parents have learned something very specific about what their child, their young adult, was thinking, but they don't learn it till much after the event. But a slightly more optimistic view comes from James Barry, about the author of Peter Pan, on encouraging youth and allowing us to make it flourish. And that's really what we should be about. Understanding the nature of the beast in front of us, the difficulties that an adolescent is going through, but also looking forward and thinking, actually, this is a great resource. This is an amazing thing that's coming through into our world, and we need to find a way to bring it on. And the same is true in healthcare as it is in schools, and in every other facility where we encounter adolescents. And so there's childhood and there's adulthood, and there's this very squiggly, tricky phase in the middle of all of that that we like to think, or that we like to call adolescent. Well, how do you find it? How do you define it? Where does it begin? Where does it end? Does it ever end? You know, how do you get somebody through all of that? And there's an awful lot in just thinking about that. From a healthcare point of view, really this defines adolescence. What we're thinking about is not moving teenagers from one place to another or one doctor to another. What we're looking at in adolescence and in transition is really trying to teach somebody who is young to build their own independence. Now, when you start to talk about banking or getting yourself to and from school, that's obvious, that it seems obvious that in a phasic way, you'll start to encourage your child to learn about saving money, putting it in their piggy bank, saving it up, and then going out and buying something they want to buy. You'll start to think about incremental moves towards getting them transported to school. Those are obvious things that we do. But actually, it's much, much more difficult, I think, to encourage somebody to take on responsibility of their healthcare, because it feels like such a dramatic step. Some parents and some children seem to be able to phase into it really naturally. Some are much more guarded and much more scared, much more wary of that whole process and of releasing responsibility of care to their child. And it's understandable. You've been through 15 or 16 years of what can be an extremely rocky road and very difficult journey. We heard just before our break a minute ago from Britton Douglas what an immensely troubled journey or bumpy journey that was, and how they got through it all together. And so it's not surprising that at times some parents find it really difficult to let go and to release responsibility to this 15-year-old who shouts at them when they say, put money in the piggy bank, brush your teeth, get up, make your bed, tidy your room. And suddenly we're releasing to them responsibility for their own healthcare. It seems very incongruous, really courageous, and very difficult to do. But that's exactly what we're trying to do, is to encourage these teenagers to develop their own independence in healthcare so that they can, in the longer term, take on, make decisions, and engage with their own healthcare providers so that they have that responsibility, they have that ability through the rest of their lives. That's what we're trying to define and trying to do. In the UK, there are several guidance documents that help us and support us, and they're very global. They don't focus on any one particular area. So if you read them, distilling out the relevance to any one specialty, including urology, is quite difficult. But actually, it's there. The basis and the ethos is there, just as I've described to you. What we're really talking about is this phasic preparation. trying to encourage people to have conversations early on so that as they move into as they move through pediatric care, conversations start to develop about a child understanding their own condition. And there are various ways of doing that. There's no right or wrong. And in fact, if you have a system in your hospital, you may even individualize that to patients as they pass through, because everybody's different in the way that they approach the way that they deal with information. So understanding those differences is really important, and trying to be relatively flexible or fluid about the way you approach any one individual or family, I think, is an ideal. But phases where we start to get them to talk about what's gone on with them, what condition they have, what matters to them, and start to build that rapport so that they become much more the driver of the conversation rather than the audience to the conversation that's going on between their doctor and their parents. They start to become the driver or the major participant in that conversation. And then as they get more and more able in that, then we can start to think about moving them to a set of healthcare providers that can look after them into their adult life. And there's no one model for a healthcare provider that can look after somebody in their adult life. There are lots of different systems, lots of different ways of doing it. So there's no right or wrong. Again, it depends on where you live, where your doctors work, the environment that they're in, but designing a system that incorporates that as part of that environment. And we know, or we're starting to learn, I should say, that there's value in that. And so we know that if your child is born with a condition and they are working through transition well, so there's engagement throughout their adolescent life, that in some areas of healthcare there's been good data showing that there are improvement in healthcare outcomes. The particular ones that we're talking about are asthma, diabetes, oncology, and one or two others too. Rheumatology is another example. There aren't the vast amounts of data in urology as yet, although I'm going to show you some examples as we go on. And that's because in general we're dealing with rarer conditions. Lots more people have diabetes, lots more people have asthma, and so there are good data and discernible outcome measures that allow people to determine what's good and what's bad, and engagement with healthcare. So as I've said, there are different ways that you can do it, and no one of them is all, but I've used this model now in 2 or 3 things that I've written over the course of the last 12 months or so as an outline for how you can design a transition service if you're a hospital needing to do that. You can either have your paediatric doctor follow you right through as part of an integrated department, so a paediatric doctor that's working both in the paediatric realm and the adult realm, and that can be all integrated within one hospital. Sometimes, as in the second example here, that paediatric doctor may do the same thing, but they move from that paediatric environment into a more adult environment that's across the street or 2 blocks along or however far it is, but they continue to look after their patients in that way. And there's good and bad about that. But at some point, it's likely that that paediatric doctor is going to have to retire. And so at some point, there will be a change in healthcare provider. So there are advantages to it because they may see you through adolescence, and so that change of healthcare provider, that transfer, may happen just at a different phase of life. You can argue that either way. The third model is really what we do in London. So, as I said, I'm an adult urologist by trade. I work very closely with my paediatric urology colleagues. We perform a transition clinic at the Paediatric Centre, and then we bring people over to where I spend most of my time at University College Hospital London, and we integrate them with our team when we start to take on the care into their adult life. We don't pass them on to anybody else beyond that, so they become our patient for life, so to speak, and we aim to provide then continuity on that basis. So there are different models. What we'd like to avoid is the last model, where patients are looked after until a set age because of the resource that's around them, so the hospital may not be able to look after them at a certain age, their insurance may lapse after a certain age. There are various examples of reasons why that may happen, but to have no ongoing plan and for any healthcare that they need beyond that to become crisis management, because that can't be ideal. It's costly, it's worrying, and there are problems that may be missed as a result of that. So we'd aim to avoid that. This is just an example of the things that come through our clinic on a day-to-day basis and what we see. So there's a range of congenital anomalies and other things that we see too that we deal with. Exstrophy is a large part of that because I deal with one of the two major, or I work very closely with one of the two major exstrophy centres in the UK, and so we see an awful lot of exstrophy and have a great deal of experience with it. But that just gives you the background of conditions that we look forward to looking after. I've made the point a number of times already that there's no way that I could do this alone. That's my team. That's the lunch queue. But we have a number of different people that we work with, and that's really, really important, as I said. These are examples of some of the things that some of the groups that we have to integrate with to deliver appropriate care. And that's not exhaustive. There are other people that we involve, and we do that on a bespoke basis. So when there's a particular need for a particular patient, then we'll bring in that need, or they'll go out to that need in order to provide the level of care that they need. And you can see it's a broad range covering all sorts of different areas and all sorts of different people that are involved in the healthcare of the young adults and adults that we look after. So when you think about it and you start to understand the effects that we're talking about, then you can understand why as a team we need that breadth of expertise to help us deal with, because we're dealing with all sorts of impact on a young person's life, not just the urology side of things. Urology is our focus, that's what we're good at, but there's all sorts of other aspects that we need to be part of, and all of those things come together. Some of them they were born with, some they encounter early in life, and some will be functional disorders or disorders that they develop for a variety of different reasons within themselves that spit themselves out and become adolescent urological issues. And our service covers a range of those, some very anatomical in their basis, some much more functional, some much less easy to define, but we deal with them all as part of our service. Some of my adult colleagues argue that I'm unnecessary. Can you imagine that? But they'll say that, you know, adolescents, you know, they're capable of doing everything that we do. They're old enough to vote, they're old enough to order a beer, they're old enough to spend their own money, they're old enough to have sex, and therefore they don't need adolescent doctors. There's no additional expertise needed. And I would argue very strongly against that. It's really important to understand that although many of them look like adults and they behave in some ways like adults, there are differences. They're sometimes subtle, they're sometimes difficult to pick up, but they are important, and particularly when you're trying to engage a young person who could be interested in anything other than healthcare, and generally is interested in anything other than healthcare. Trying to engage them, it's really important to be cognitive of that. Understanding that the adolescent brain doesn't finish developing until really you're into your mid to late 20s. So that emotional maturity, the things that we now take for granted, continues to develop right through into your late 20s. So the propensity that we see in adolescence for risk-taking, doing things, railing against the system, fighting against everything that we see is not something that they're doing deliberately. It's something that they're doing as part of their cognitive, their neural, their brain development. So understanding that and being part of that journey is really, really important. I love adolescents. I think they're hilarious, I think they're challenging, and I think that at times they drive us all to distraction. I love the fact, I'm sure there's a lot of sympathy in the room all of a sudden. But I think that at times, you know, I see patients who come through the door who will barely utter a word. They don't want to engage. And in fact, just getting them through the door on the part of their parents was a huge achievement. And not underestimating that, I think, is important. And then, you know, over the course of 5 years or so, they'll sit there and mum or dad will nag at them for not using their catheters, nag at them for not washing out their bladders, nag at them for not drinking enough. And they won't really engage with that conversation. They'll be the, oh, yeah, whatever, conversation that goes on. But then about 5 years later, they'll come through with a boyfriend or girlfriend. And the boyfriend or girlfriend will say, I think you should wash out. Yeah, no, I'll wash out. I'll definitely wash out. I don't know what the difference is, but it's definitely there. understanding that adolescents are going through this process and that there are differences that they need to be accommodated within the realms of reason are really important in terms of how we handle them. So needing plenty of sleep, allowing them to sleep at times that are reasonable for them. There's lots of good evidence about how that improves learning, how it improves engagement, and so I'm not a sleep expert, but I put this in just to remind us to try and accommodate some of those adolescent behaviours, even though sometimes it puts our blood pressure through the roof. But we know that there are difficulties in adolescence, and these are data from the UK just telling us about the problems with getting people to drink, getting them to eat healthily, problems with obesity and tackling those. And they're real challenges, and they face all adolescents, they face all of us. But actually, you're trying to integrate somebody through healthcare, keep them engaged, make them do their catheterization, make them go to the bathroom when you want them, drink plenty, do everything they want to do, in an environment where all of this normality is going on around them, and yet we've got to incorporate their extrovert side of things too. It's really important to be mindful of all of that. It's also really important to understand that in many ways, the children affected by extrophy are normal. They've got all sorts of normality going through them. And so it's quite normal for them to think about how they look. I have, I'm sure you have. And so there's no reason why they shouldn't. It's quite normal for them to say, I was born with bladder extrophy. How does that affect the way I look? How does the operation that I've had affect the way I look? How does the fact that I have to catheterize affect the way that I'm going to integrate with my friends? Who do I tell amongst my friends? And when I do tell them, how will they react? And how do I manage that reaction? And when I reach the point where I want a girlfriend or a boyfriend, how will they react? How do I allow that to happen? And who do I trust when I start to allow that sort of thing to happen? Those are really important things that every single person in the room has asked themselves. But unless you have to layer on the extrophy side of things, or hypospadias or posterior urethral valves, the other examples I've talked about, actually understanding that interaction is really, that integration is really difficult, but really important when we come to try and be sensitive about how we manage those aspects in adolescents and young adults' lives. We're really lucky at UCLH. We have a specific adolescent ward, we have a specific adolescent team, and that helps us. It helps us to deal with some of those more complex issues. But once you get beyond that age of 19, which is the National Health Service's definition of being an adult, then we start to lose some of this. It becomes very difficult to maintain or get psychological support, for instance, for anybody beyond the age of 19 years. I've no idea why that's true, but it is true. When you're looking at adolescents as doctors, these are kind of things that they're looking to assess in terms of understanding what's their home life like, how are they engaging with education, are they doing normal activities with their peers, are they playing sports, are they joining clubs. We'd start to think about, are they taking drugs, are they eating normally, do they drive, do they have independence for themselves? And of course, we want to think about mental health. We want to think about, are they sleeping and would that impact upon their mental health? And we want to think about their relationships and how they're getting on with that. And so, again, I'm just a surgeon. There's a huge range of people who are much more expert in many more of those areas than I am. So one small part of a team. But when it comes to dealing with complex problems, I've alluded to the fact that that team is really important. So trying to think about all of these areas in the care of an adolescent is really important, medical or surgical, dealing with the psychological side of things, and the treatment or the therapy that they may need as part of that is important. Not everybody needs therapy, not everybody needs psychological support, some do, and teasing out those people and making sure that's available for them is part of the challenge. So when we think about the urologist's aspiration for an adolescent who's on this journey that we've talked about, we know that a lot of these patients, a lot of patients with extrophy are going to need bladder surgery. We're going to need to think about how, when we do surgery for their bladder, how we protect their kidneys. We're going to need to think about how we make their appearance as acceptable as it can be for them, and then we think in the future how that impacts upon their health, how that impacts upon relationships, how that impacts upon their ability to be educated and to work as part of that. All of those things start to form a picture that creates their quality of life. And so from the perspective of a patient, some work that was done by my predecessor looked at extrophy patients and what they wanted. And one of the things that they stated so often was just, I'd like to be normal. And I don't know how you define normal. I don't think I'm normal. But I think, you know, but I don't know how you define normal. But there are some discernible things that people pick out. So normal is being able to make the same noise in the bathroom as the person in the next cubicle. So when you pee, you make the same noise. Normal is being treated in the same way as everybody else in your class or where you go to work. So not having to have your own bathroom. Having to have your own bathroom, or even having to go for yearly hospital appointments, create something that's different to most of your friends. And understanding and incorporating that is really important, because those things may be important in terms of providing good healthcare, and teaching somebody how to accommodate that and to deal with that and to bring that into their life and embrace it is part of the challenge that we're all set to deal with. The extrovert patients that we deal with very enormously, and whether or not they'd like to have an umbilicus or a belly button. And so trying to deal with that, trying to incorporate that, and when they really want it, find a way of achieving that for them is important. They will go through a phase where they're sick to death, or they often go through a phase where they're sick to death of seeing healthcare physicians of any sort, and so they just want to be left alone. Dealing with that rather rocky period and helping them through that, allowing people to come through the door when they want to, trying to maintain some sort of contact and keeping them safe is important. So all of those things form part of the challenge that we have to recognise, we have to try and help people through with, help people accommodate in their lives so that they can feel as normal as possible. This is just an example of somebody who's had their belly button rebuilt for them so that they can feel happy. That's what they wanted, and that's the surgery that they had. So I'm going to drift away slightly from extrophy just to show you, you'll remember the slide that I put up right at the start saying why. Why is transition, why is long-term healthcare really important for our patients? Some of this will be about extrophy, some of it not, but it's important to illustrate, I think, the value of engagement in healthcare, and therefore why transition is important, because we know that helps to improve engagement with healthcare. One of the things that neurologists have known for a very long time is that if you have spina bifida, so damage to the nerves that come out of your spine and affect your bladder and bowels, that one of the problems is that it can create a very high pressure bladder, and that can damage your kidneys irretrievably in some cases, and that actually many young patients used to die as a result of renal failure because of the way their bladder behaved. What we learned from this study that was carried out from a hospital in London called St George's in southwest London was that actually by managing that bladder well, by treating it aggressively early on in life, that actually you could almost reverse that trend, that you could get rid of deaths from renal failure. And we've learned that by virtue of the fact that these patients have been engaged in a long-term follow-up program that's taught through looking after patients into adult life. It's allowed adult physicians to talk to pediatric doctors and say, look, actually what you did here was a great thing. You've changed lives. In fact, you've massively improved survival by doing that. So, and there's no way of knowing these types of things unless you have a group of patients that are engaged in healthcare, that are doing the right things by themselves, and where the doctors that are looking after them in the long term are able to report back and say, what you did on day one was really important, because that's changing lives for populations, improves survival. And so you can see here that in fact there were almost none in this study that died from renal failure at all. It's the same study. So that's really important data. And the value of transition to you as parents, to your children, as patients, I've tried to talk about. This is now the other side of the coin. This is what we as doctors learn from long-term healthcare. And it's just as important globally in terms of how we improve care and we look after people for the future. So we can also talk about how when ladies who have neural tube defects or spina bifida can change the outcome for themselves when they start to have children themselves. We know that if you have a neural tube defect, spina bifida, that actually you're at much greater risk compared to the normal population of having a child that's also affected by the same thing. But we also know, we've learned, that if you give high-dose folic acid for 3 months before you become pregnant and for the first 3 months of your pregnancy, you reduce that risk by half. So that's another major step forward. That's something we've learned by looking after these patients for the long term, keeping them involved in healthcare so that they benefit, but also we learn from their experience and the other stuff that we do over time. Hypospadias is something that we see a lot of, and there have been various theories about how we can improve the outcomes of surgery early in life, and we can improve data for the long term. And some data overall that was published last year, there's a lot of theory that actually we can improve things by giving children testosterone around the time of their surgery. And there's a basis behind it, and there are some people that still believe it, and some people that will have data that supports it. So I don't want you to walk out of the room, go and talk to a friend in the pub who says, or the bar, and says, my son had hypospadias, he had testosterone, and for you to turn around and say, well, that was wrong. That doctor stood up and he said it was wrong. There's a huge bandwidth of what's appropriate and what's not appropriate. And when you're dealing with complex disorders, understanding that some things will be more right for some people and more wrong for others is really, really important. So you have to have a tolerance to this data. But we know that by looking at long-term data, that in lots of patients where they would previously have been given testosterone, it's very difficult to show difference. And so we can start to think constructively about how we'll inform healthcare for the future. We know that there were some hypospadias surgeons around who said that actually you don't need to follow up hypospadias patients for the long term, because once you've gone 2 years beyond their original surgery, they don't need follow-up because they don't get complications. Well, we've learned now that there are data out there that show us that lots of people still do very well, lots of people still don't have complications, but the length of time between their surgery and their complication may be much longer than we thought, and there are probably more patients that develop problems as they go through puberty and into adulthood than we'd expected. So there are important things for us to understand when we counsel patients, when we think about their long-term treatment, and when we try and to maintain them engagement through that drum that I've been beating about transition. And so this is just a set of data that my friend Pete Hobecker from Ghent put together for a publication that we published earlier this year, looking at the outcomes for hypospadias. We've also learned that it's really difficult to collect data in almost any of the conditions that I'm going to talk about, that I've talked about today. And the reason for that is that if you get a young man or a young lady that comes through your clinic door and you operate on them early in their life, the chances of them moving, changing doctor, falling out with you, falling out with another member of your team, deciding that they want to do something differently, seeking a second opinion, all sorts of things changing in their lives is huge. So just maintaining people in a system on the basis of their own lives is a real challenge. Maintaining enough healthcare resource to look after every patient that comes through the clinic door and has an operation early in life is a huge financial challenge. And if I were to say to Dr. De Filippo today that he had to look after every hypospadias patient that he operated on for every year through the rest of their lives, we'd fold the system really quickly, because that's a much more common condition, and we'd overwhelm clinics by doing that. So we have to think carefully and sensibly about how we try and do that. But we know that collecting data is really difficult, and so our outcome data at the moment is not the same as a condition where it's much more common and cases tend to be concentrated, such as prostate cancer or kidney stone disease or renal cancer, where things tend to be much more concentrated and the conditions themselves are not so rare. So following on from that, if you think about exstrophy as a condition, which aspects of it are lifelong, which affects patients throughout their lives? Well, we know that it's all of these things. And there are sine waves of effect. There'll be some days when they're worried more about their bladder function, some when they're worried about urinary tract infections, some when they think about fertility, some when they're worried about catheterization or body image. All of these things affect patients born with exstrophy throughout their lives to a varying degree and and different times throughout their lives. And that's our challenge, to recognize that and help them deal with those challenges as they arrive. We know, for instance, that long-term follow-up of cystoplasties is really important. We know, or it was thought for a long time, that it was important to survey these bladders because there was a risk, a concern, that they might develop cancer in adult life. We know now that actually that data is nowhere near as alarming as it once was. We know that it's still important, but we manage it differently now. We look at that from a different point of view, and that's again because of long-term follow-up and how we can manage that better. But we start then to challenge ourselves about all the things that we can see, all the things that you see, and how we should start to measure that so that we can give you meaningful data and better understand that ourselves. And that's, from a medical point of view, a real challenge. And so if you think about a patient born with exstrophy, we heard brilliantly just before we went for our break. We heard brilliantly the concerns around. But you saw those really graphic slides of a spica cast and external fixators. So we know that there are orthopedic implications to exstrophy. We know that because of the way the bladder is born, facing out onto the abdominal wall, that there are going to be urinary challenges. And we also know that because of the way the genitalia are structured in exstrophy, that we could measure sexual outcomes and try to understand differences from those point of view. So as a group of doctors, how do we understand that, and how do we measure that, and how do we make that meaningful to our patients in terms of what we interpret? So there are data out there about hip and back pain associated with patients with exstrophy because of the change of shape in the pelvis and the stresses that go through the hips and knees. They're not good data. There's not lots of data out there that say if we do this, this will definitely change. We'd like to build that. We'd like to understand that better. But we're getting to a stage now where we may be able to do that because of the networks, because of the integrated working, and because of the recognition of long-term follow-up. We're starting to see the ability to do that. We won't have answers just yet, but we will start to develop those. We understand that with the forms of diversion that we know about best and that have stood the test of time, that lots of patients have needed forms of urinary diversion. You may well be familiar with those. And that when we augment bladders or we look after patients who've had urinary diversions, that they're at risk of forming stones in their bladders and to some extent stones in their kidneys. And that at the moment, the adult population of exstrophy patients rarely void spontaneously. They often need to catheterize. So we know all of that. We know that when it comes to sexual outcomes or fertility reproductive outcomes, that exstrophy men have certain abnormalities that affect their penis, and that can make them worry about being able to have sexual intercourse. Sexual intercourse is very possible for very many of them and should be so, and there are things that we can do to help with that. We know that for some there'll be impacts on fertility, and that's important to recognise and support. And we know that there are some elements of sexual dysfunction as part of that. But again, lots of that, we can accommodate that. Many of our patients go on to have really happy, healthy family lives in every sense. But we need to keep our patients engaged with us. And that's part of the challenge that I present to you today and part of the work that we do. Because if they don't, if they disappear, then things will change for them. Most patients that have augmentations in their bladder, so they have bowel in their bladder, will produce mucus, and they need to learn to manage that. We have specialist nurses and experts who will help them with that. We know that wherever you put bowel, it continues to behave as bowel, and those two bits link together. And so we know that we need to keep a check on their metabolic status. It's really important for the long term. We also know, as I've mentioned, that they're in danger of forming bladder stones that we sometimes have to remove. The most bladder stones I've ever removed from one bladder is 49. That's a lot. But we know that there's stuff that we can measure as doctors, and that's really important because we can see it, we can measure it, there are tests that we can do. Some of the stuff that we need to be aware of, as I talked about, oh sorry, I thought that was going to highlight, I beg your pardon. Some of the stuff that we know about is harder to measure, and we can only start to see it when we have experts involved that look at things specifically. But, you know, when we have patients that are worried about changing clothes in front of others, in locker rooms or wherever, who think that they look different and who are worried about telling their friends about their condition, then we have to be mindful of that. It's not always overt. It's not something that necessarily sits up and begs in a clinic and asks you to ask about it. But if you're going to undertake this kind of work as a doctor, then trying to be aware of that and trying to gently raise those kinds of questions, engage those conversations, is an important part of what we try to do. It's sometimes difficult to begin those conversations, but if they're not raised for us, and sometimes they are, then we have to raise those conversations. So when you're seeing doctors, particularly as your son or daughter approaches adolescence, don't be surprised if those conversations are raised, because they're important. And you may be asked to leave the room, because I don't know about you, but if I was asked to talk about sex in front of my mum or dad, I'd blush, I'd struggle. So recognizing that's really important and allowing room for that is really important. We understand that there are some impacts on sexual function, and I think that data now are improving. So although these data look rather pessimistic, there are some impacts on sexual function. We know that for ladies with extrophy, that they can go on to have really good, happy, healthy sex lives. We looked at it. We found, when we looked at our group of female patients, that 80% of them had had their bladder made bigger. Only 20% in our group had had osteotomies. Some of you will know what mitrophonos are, and just over half had had those. There are issues with continence. When they meet me, usually in their teens, they've had a mean number of, so an average number of 8 surgeries before they meet me. Lots of them have issues with UTIs, and there are other healthcare problems too. But most of them, about 80% or so, are engaging in sexual activity. Some didn't want to tell us, that's fair enough. Some of them need a small vaginoplasty, an adjustment to their vagina to allow them to engage in sexual activity, but it's important that these conversations are had, and that's why I've included this data. I've put this slide up because if Roger and I both had a cystoplasty, we had a piece of bowel making our bladder bigger. If we both had one and we both did a urinary pregnancy test, one of us would show up as being pregnant, because we know that there's a false positive rate. Once you introduce bowel into the urinary tract and you do a urinary pregnancy test, then there's about a 50% false positive rate. So if your daughter has extrophy, if she has bowel in her urinary tract making her bladder bigger, then it's really important that she has a blood test to diagnose pregnancy if she's thinking of becoming pregnant. Things to be aware of. That's the data from the publication that we put out a few years ago. We talk to our patients about fertility and about the ability to conceive children, and because we know some of them may struggle more than others. There's no reason why they shouldn't have children. They can, but they may need assistance in doing that, and that's what these data here are really designed to show. We know that patients who've had complex surgery on their urinary tract can have problems through pregnancy too. And so in our centre, I work very closely with a high-risk obstetrician, OB-GYN, and together we offer joint care through a lady's pregnancy so that we can get them through and deliver them safely at the end of that. When we looked at other data from other centres and other studies, we found similar pictures, not all the same, but similar in terms of difficulties and complications through pregnancy. We found that we had a lot of patients who delivered very successfully. We found that there was this high miscarriage rate in our group. We suspect that those are not true miscarriages. If you think about the pregnancy test slides that I showed you a little while ago, we suspect some of those were false positive pregnancies, and so that's why we're seeing that high miscarriage rate. But we did know, or we do know, that if patients are not looked after in centres where you're able to provide that shared care, there does seem to be a greater risk to the baby and potentially to the mother too. So that specialist care is really important. We know that there were other things like postpartum hemorrhages, that you could damage the anatomy, and there were occasional other problems too. So again, all arguments for that level of specialist care that I've talked about. But what I wanted to get to was this. So this is one of our patients, and I'm very, very nearly at the end now, but this is one of our patients. You can see she was born with bladder exstrophy. She has a Mitrophanoff catheter that's coming out on her right-hand side. Throughout her pregnancy, for the latter stage, because of the change in her Mitrophanoff, she couldn't catheterize it as regularly as she wanted to. It became too difficult. And so they put an extra long catheter in, and that just stayed in most of the time, was changed when it really needed to be changed. And that was a good way of managing her pregnancy. And the result of that, all of that, is that. Okay? So it's an enormous privilege as part of my job to get involved with patients who have such positive outcomes as a result of long-term care and the engagement that transition has created in achieving that long-term care. And I can't overemphasize to you enough the importance of keeping your child or keeping yourself engaged with that if you're born with bladder exstrophy. And then a final note. This is a table. We did a survey in our clinic looking at patients that came through our clinic and what they did in the long term. Because it's often a perception that they grow up, but they are so dependent on their healthcare, they're unable to engage and do the things that you would expect them to do. And what we found, if you look at this, the exstrophy group here, was that just over 2/3 of them were engaged in highly skilled or professional work and doing extremely well in that. Yeah, I have got this here. Okay, so this is our slide. It's all of the patients, so it's all those disorders that I put together. Only 8% of them were unemployed, and in fact, the exstrophy group, it's only 6% of them were unemployed overall. But we have a much higher proportion of doctors than you'd expect in the general population. I've no idea why that is, but we do. We have an ITU nurse, a bomb disposal expert. We weren't sure whether we should put him as skilled or professional, but we decided on the basis that if we needed him, we really wanted him, so we said he was professional. The comedian too, you know, I don't know how much of a living he makes on that, so we decided we'd keep him as skilled. If he gets better, we'll call him professional. I guess that's just the way it works. Okay, as I said right at the start of my talk, I'm truly grateful and truly honoured to have been invited to what I believe is a very, very special meeting. To Pamela and the other organisers in terms of putting this together, huge congratulations, because this is an amazing group. And to have people flying in from all over the world, sometimes when I do these talks, I know that I'm going to be the furthest travelled. I know that I've been way beaten, hands down, by the lady from Sydney that I spoke to just during the break. So it's a real honour to be here and to try and share with you what I think are the important aspects of transition. I've tried to talk to you about the fact that I think that we have to understand what adolescent means to any teenager, and we have to try and understand what healthcare needs impact upon adolescence, and therefore guiding someone through transition, helping them to become independent in that realm is really important. And that's what my service and others like me are trying to achieve. We're not unique, but we're very fortunate to be part of that. So the conditions that I've talked about, and in particular exstrophy, are lifelong, and getting young adults through our services and helping to keep them engaged and independent with healthcare are really important. Knowing about their surgery in childhood is important if you're going to provide that kind of service, and understanding what the implications of that are important for everybody. We're just starting to understand long-term outcomes better. So we're just starting to work more collaboratively because there are now increasing numbers of centres who are specialising, and so the data becomes realistic to get our hands on. It's been really difficult before. We've come through a generation where 50 years ago, patients who were born with conditions like this may not have survived. A hugely innovative, courageous group of surgeons who took things forward, who made a real difference to the care of these patients, and then our generation of surgeons who started to inherit that. And so it's our responsibility and the responsibility of those after us to try and do better at better understanding the long-term outcomes, and much more work is needed in that, and I need a lot of friends to get me through and make that real difference. So I wanted to say this. I came across this quote the other day, that you're braver than you believe, stronger than you seem, and much smarter than you think. I'm really happy to answer any questions if there are any.
I'll start.
Okay,
Just to warm up the crowd.
let's do it.
One of the questions I had was, has any work been done to try to determine why bladder exstrophy occurs? Because obviously this seminar and conference is really focusing on the after effect. As a parent, I was always curious, what caused this to happen? And with all this effort and energy is being put into how to deal with as you go into from childhood to adulthood, how much energy is being put and effort put into what's causing this, and can we eliminate it from happening at all?
Sure, it's a great question. And I think that the answer is yes, energy is going into that. We don't have an answer yet. There was a paper published back in the early 1980s by a guy called Steve Shapiro that felt that this was a familial thing, that, oh yeah, there you go, that felt that this was a familial thing, that it was passed from one generation to the next. But the evidence around that actually seems to be disappearing by virtue of the fact that we have this concentration of expertise. There's a big project in the UK at the moment, and there may be other projects elsewhere that I know less about, but it's called the 100,000 Genomes Project. And in urology, our clinic was the biggest recruiter in the UK, and all of our patients were asked as they came through the clinic, would they be prepared with their families to engage in this, to have blood drawn and their sample sent off to look for genetic analyses to try and find out if there was a specific cause behind exstrophy or any other condition that we see on a regular basis. And at the moment, there hasn't been any data, or the data are really early from that yet, so we haven't seen full results yet. But who knows, we may discover associations with that. Hi. I don't know who was first. Sorry, I was...
Sorry. I had a question. So from the women with bladder exstrophy who became pregnant, how many of them delivered vaginally, and then how many of them had C-sections?
Again, a great question. And so there are centres out there who will take ladies with bladder exstrophy who are pregnant through a trial of labour. And but increasingly, and our view has been that we don't have 24/7 cover to be able to provide an expert urologist who knows the patient in the middle of the night at 3 o'clock when I might be somewhere like LA. It's nearly impossible to do that. And so what we have tended to do is with our obstetricians is to build a service where we plan for an elective cesarean section at around 37, 38 weeks, which my OBGYN colleagues tell me that that's the best time in terms of a baby being well developed and avoiding or minimizing any other problems such as lung difficulties. And that's what we do. So I'll be present at the time of delivery. I'll help with the initial dissection and then and finding the uterus, and then my colleague Pat O'Brien will do the glory bit and deliver a marvelous baby.
And then did any of those children also have exstrophy?
In our experience, no. Or in my experience, absolutely none. My colleague had one patient with a related condition, but not bladder exstrophy. And so our experience has tended not to be that case. And we deliver between about 5 or 6 babies a year. So I've been doing that for 10 years or more now. So no, not yet.
So I guess clearly, like, bladder exstrophy is something that affects primarily the urological systems, but obviously we all know that it has implications elsewhere. There's like bowel problems and sexual dysfunction that can occur. Are there studies being done specifically to find other comorbidities for things like, I don't know, things as kind of random seeming as autoimmune disorders, or other maybe more related seeming bowel and gynecological issues?
Sure. That's the most difficult question I've been asked so far. Congratulations. I think that, the answer is I don't know of all the studies that are going on. I think that in terms of related bowel issues, some of them may be primary, and in so much as anybody in the room can develop a bowel disorder, so can extrophy patients. And so we need not to try and attribute everything to the fact that somebody has had extrophy. There are certainly some secondary bowel problems, so patients who've had bits of bowel removed to expand their bladder or for other parts of restoration, that can also have an effect. And we heard from Britain about the difficulties with bowel obstruction that she'd had a number of times over the course of her early life, and the importance of understanding that. In terms of the gynecology issues, we've written something about that. Some of the data that I talked about was related to gynecology issues, and there are other authors too from Germany and from the States, particularly in Baltimore, that have written about that. And I work very closely with our gynecologists. I think they were on the multidisciplinary slide. I hope so, otherwise I'm in a lot of trouble. But yes, we work very closely with that, and so we've tried to publish data on that. It's really difficult because extrophy in ladies is about a third, it's about 3 times more rare than in men. And so getting big groups of patients together and then getting prospective data on it that means something, it is a challenge. As I said, I hope that with bigger specialist centres and the ability to work more as networks and more cooperatively, that we'll start to see that. Hi.
I have a question regarding the bladder. So a native bladder is like a balloon, so it fills and it empties. But an augmented bladder seems to change its shape.
Sure.
And so then you can end up with pockets that hold urine in it, and you can't get that urine out, so it sits there and can, make the stones and that. So is there any research being done on different ways to augment the bladder, like stem cell and grow their own bladder, or anything else that's used?
So Children's Hospital LA, they do a great job for themselves at telling people what's going on, but are doing a huge amount of work in terms of tissue engineering and the possibility of reconstructing parts not just of the bladder, but of other parts of the bladder that may have a place in future medicine. There are other groups across the US and across the world that are doing similar kind of work. So the answer is yes, there's work being done, but it's work that's been going on for at least 20 years and probably more than that. And we haven't yet seen an outcome of that where we've been able to say that is the answer and we can apply that in the clinic. And so there is a lot to producing a bladder. We think, that a bladder, as you say, fills and empties. It should be relatively straightforward to do that. After all, you can build a party balloon pretty easily. But a bladder is at least a 3-layer structure with cells that talk to each other, cells that inform those cells and talk then to our upper systems, and a blood supply. So that's at least 5 or 6 different components that somebody's got to grow, and then 5 or 6 different components that have got to integrate to make that bladder work and do the job that we want it to do. And then we've got to know the safety of the cells that we put into that bladder, that we've grown to put into that bladder. Are those cells going to be safe? Will they change over time? Will there be other problems that we create as a result of doing that? So it would be great to stand here today and say, yep, there's going to be a tissue-engineered bladder and it'll be out there for us all to use tomorrow, because not being able to use or not using bowel would be fantastic. I think that actually in the immediate term, the more likely path to success are that we're seeing a change in the way that some people are approaching bladder extrophy and the techniques that are being used. And the fact that by doing that, the bladder is being encouraged to fill and empty in a more natural way at an earlier stage in life with a more dynamic stop system or sphincter at the bottom of it in some new techniques may be the path to greater success. What we know is that there are surgeons out there that are doing different things, that the outcomes initially seem to look good. We'll only know in 10 or 15 years' time whether those outcomes really are good, but there is stuff going on.